time this lecture is being given. Any feedback regarding anything you'd like to see included in the future or feedback in general would be greatly appreciated. As you might imagine, this was not a super fun lecture to prepare. People do horrible things to children, and the sky's the limit on what people will think of. So why are we talking about this subject? This lecture was actually created as a result of multiple requests over several years for more information on the topic. There are several key points I want to cover today. First, it's important to be aware of the unusual manifestations of child abuse so cases are not missed and children further harmed. Second, when a child presents with an unusual or unexplained injury, abuse should remain high on the differential. Third, as with abuse in general, a multidisciplinary response is necessary. Scene investigation and forensic interview are crucial, as sometimes a child's disclosure may be the only evidence of abuse. Finally, consultation with providers with specialized training and experience in child abuse pediatrics may be helpful in evaluation. To prevent some of the secondary trauma I experienced reading through the literature on this, I have done my best to minimize the more disturbing details of the cases and images in the cases I will be presenting. The first section I'm going to talk about is forced ingestions and poisonings. Forced ingestions are surprisingly common and range in severity from washing out a child's mouth with soap to cases of torture in which a child is forced to eat things like insects, vomit, or feces. We also see forced ingestions in practice with some regularity. For example, 2 brothers who were being evaluated for physical abuse also reported being made to eat oatmeal with substances like mayonnaise or mustard added when they misbehaved. Another little girl who was being seen for injuries caused by her mother hitting her with a belt reported that when she was younger, she just had to eat Red Hots. While I don't think any forced ingestion is appropriate, the following forced ingestions are more widely recognized as clearly abusive with potentially life-threatening consequences. The mouth is often a target in physical abuse because of its role in communication, such as crying or talking and feeding. Most cases of forced ingestion involve children younger than 5 years in age, and the intent is often punishment. Usually a false history is provided if the child does present for medical care. Ingestions may be forced by verbal or physical means. So a child may be told to ingest a substance and do so out of fear, or a perpetrator may pry a child's mouth open, sometimes resulting in injuries to the mouth, face, or neck. Injury to the nose can also be seen if a perpetrator pinches the nose shut in an effort to make the child swallow. The primary risks of forcing a substance into a child's mouth is related to the anatomy of the mouth and throat. There are really only so many places a substance can go. A child has to either swallow or inhale the substance, leading to injury to the GI tract, or systemic absorption or aspiration. Saucing or hot saucing is a form of punishment that involves using hot sauce on a child's tongue for behaviors such as lying, biting, hitting, things like that. This method has been around for years, but has been made more popular recently because of several proponents in the popular media. There was actually a case not too long ago in which a mother appeared on national TV with a video showing her pouring hot sauce into her 7-year-old son's mouth and then putting him in a cold shower because he'd gotten in trouble at school. The little boy is sobbing and screaming throughout the video, and as it turns out, his 10-year-old sister is the one taping it. The mother in this case was ultimately convicted of child abuse. While there's a spectrum of what type and how much hot sauce is used, the practice is not without risk. The substance that makes hot sauce hot is capsaicin, which can cause irritation of mucous membranes and swelling, which may be fatal in cases of unrecognized allergy or aspiration. In addition, the American Academy of Pediatrics does not support the use of physical punishment or pain to discipline a child, primarily because it may be damaging to the health and well-being of the child and has actually shown to be ineffective long-term. Pepper is another substance that has been used as punishment for children. The premise is similar to saucing in that pepper contains an irritant that causes discomfort and increased blood flow to the area, which can lead to swelling. The primary risks are aspiration, as before, as well as spasm or occlusion of the airway. In one case series on fatal pepper aspiration, approximately half the children had also been previously abused based on history or exam. While other abusive injuries may help suggest a diagnosis of forced ingestion, the author of the same case series also looked at data from local poison centers and found that accidental ingestion of pepper is typically limited to mild irritation to the mouth, throat, and or eyes. As an example of this, the first case is a 2-year-old girl who was transported to a local hospital by ambulance after her babysitter reportedly found her lying in a hallway. The history provided at that time was that she and another child had been playing in a different room, and she may have gotten into Pepper because she had once before. She was pronounced dead on arrival, and autopsy showed bruises on the upper and lower lips, as well as Pepper filling her upper airway. Scene investigation showed Pepper on the floor of the hallway where the child was found and a shaker next to the kitchen sink. The babysitter was questioned further and subsequently confessed to pouring Pepper into her mouth as punishment. The mechanism of death in this case was mucosal swelling and mechanical obstruction of the airway. Continuing on the theme of condiments, salt is another substance that is sometimes administered abusively. In humans, sodium plays an important role in fluid balance, maintenance of blood pressure, and cell function. The normal range in our blood is 135 to 145, and anything below is considered hyponatremia, and everything above hypernatremia. So in cases of salt poisoning, a child is forced to ingest salt, usually table salt, causing symptoms such as thirst, which obviously younger children are not able to communicate, but also vomiting, diarrhea, seizures, coma, altered mental status and intracranial bleeding, and death. Those at highest risk are children without independent access to water, such as infants and children with developmental disabilities, although fluid restriction may also be a component of the abuse. There is overlap in some cases of salt poisoning with medical child abuse, given the symptoms it produces. Without a history, these children often undergo an extensive medical workup looking for a medical explanation. Children can actually be exposed multiple times prior to presentation. In one case series, the average time to diagnosis was 3 months. As before, the diagnosis requires a high index of suspicion, as it may be missed if electrolytes are not checked in a timely fashion. In the case series of these children, serum sodium actually returned to normal levels within 24 hours, except in cases where it was purposely slowed to prevent damage to the brain. Another factor complicating this diagnosis is that there are a number of disorders that cause high serum sodium. Most are persistent and relatively easily to exclude, but dehydration can also present as transient high serum sodium. It makes sense that if a child is given salt, their serum sodium is going to increase. However, a child who's dehydrated will also have an increased serum sodium because there's less fluid in their vessels to dilute it. Both can also result in a higher concentration of salt in the urine. Salt poisoning as the body is trying to get rid of excess salt, and dehydration as the body is trying to hold on to as much water as it can. There are ways to differentiate these two diagnoses, however. In general, a child who's dehydrated will have fluid loss and therefore weight loss. A child with salt poisoning may have weight loss or gain depending on whether or not the child has access to water or is vomiting. If kidney function is normal, the calculated fractional excretion of sodium, or FeNA, is typically normal in dehydration and elevated in salt poisoning. In cases of salt poisoning, there may also be a history of previous episodes of unexplained hypernatremia or high serum sodium, or other signs of abuse on physical exam. Unfortunately, a diagnosis of dehydration does not rule out child maltreatment, as there are several published cases of abuse of water restriction or deprivation with increased risk in children with day or nighttime bedwetting. On the opposite end of the spectrum, forced water intoxication may lead to hyponatremia, or low serum sodium. A child who is forced to consume excessive amounts of water may develop nausea, vomiting, swelling of the brain, which can cause headache, lethargy, agitation, seizures, coma, and eventually death. Similar to other forced ingestions, if the child's not able to swallow the water, given the amount or whatnot, they may aspirate, but in this case, they effectively drown. Treatment requires flow correction to prevent injury to the brain or osmotic demyelination. As an example of this, case 2 is a 7-year-old male who was brought to the emergency department by EMS after being found unresponsive. In the emergency department, he was noted to be cold with a slowed heart rate and extensive patterned bruising. Shortly after arrival, he began to seize, so head CT was performed emergently and showed swelling of the brain. Labs were drawn and serum sodium was low at 123. He was intubated for airway protection and then was admitted to the ICU. On admission, father reported that mother had wanted him to drink multiple glasses of water because he'd really not drinking anything that morning. He also reported that mother did not like the child and had treated him differently than his siblings. Multiple services were consulted in the hospital to rule out medical causes, and all found his presentation to be consistent with acute water intoxication. Mother subsequently admitted to making him drink 3 glasses of water with dinner, causing him to throw up, after which she made him drink more. He then began having seizures. There were some concerns in this case that this may not have been abusive because the mother did not physically force the child to drink or know the consequences of forced water intoxication, and was doing the best she could with a behaviorally challenging child. Regardless of those factors, forcing a child to drink water to the point of vomiting and then making them drink more to the point of seizing is not appropriate discipline of a child. Most of the literature on poisoning as a form of child abuse consists of case reports or manifestations of medical child abuse, or Munchausen syndrome by proxy. However, in 2010 and 2011, Dr. Yin, a physician out of Cincinnati, published 2 studies using data from the U.S. National Poison Data System, a database of all calls made to U.S. poison centers. Each of these calls has an intent coded to it, such as unintentional, intentional, adverse effect, or malicious. Looking at data from 2000 to 2008, he found 450 cases per year of malicious non-pharmaceutical exposures and 160 cases per year of malicious pharmaceutical exposures in children less than 7. Overall, 22 children died as a result, and 350 had moderate or major adverse consequences. These numbers likely significantly underestimate the actual incidence of poisoning, as only children less than 7 were included in the study, and many cases are not reported or detected. Dr. Yin actually looked at the CDC mortality statistics on homicide by poisoning in children less than 5 during that same time period and found 14 deaths, a 7-fold difference from those reported to U.S. poison centers. The most common non-pharmaceutical exposure was household cleaning substances, so things like bleach, detergents, or all-purpose cleaning agents. This was followed by personal care products like soaps, shampoos, perfume, and cologne. Foreign bodies, number 5 on the list on the left, included things like toys and feces. Alcohols, number 6, included ethanol, drinking alcohol, but also included isopropanol and other ethanol products not intended for consumption, like mouthwash. Hydrocarbons included gasoline and freon. The most common pharmaceutical exposure was pain medications like acetaminophen or ibuprofen, followed by street drugs like marijuana, cocaine, methamphetamine. The remainder of the top 10 are not surprising, as most of the substances are known to have sedating properties and are relatively widely used and therefore available. Not surprisingly, like other types of abuse, the author also found that poisonings typically have worse outcomes than accidental ingestions. Finally, there are several case reports of a caregiver forcing foreign bodies into a child's mouth. As an example of this, a 6-month-old female presented to an emergency department with fussiness, difficulty swallowing, and choking on food. A barium swallow study was performed and showed a linear metallic foreign body in her esophagus. An abdominal x-ray showed multiple items, including thumbtack, screw, and carpet tack in her stomach. Other foreign bodies in the literature include nails, coins, broken glass, rubber ball, and baby wipes. Depending on the foreign body and where it ends up, it may cause perforation or airway obstruction. These cases may not present acutely if the airway or esophagus is only partially obstructed, in which case symptoms like coughing, wheezing, drooling, or difficulty swallowing may develop. Foreign body ingestions and aspirations are not uncommon in mobile young children, but abuse should be suspected in pre-mobile children whose developmental level is not consistent with being able to independently introduce foreign bodies into their own mouths. So I think we'll pause here for any questions and look at something a little bit happier.
Dr. Petska, there are no questions at this point.
All right. So continuing on, the next section I want to talk about is unusual burns. Thankfully, microwave burns as a form of child abuse are relatively rare. There are some cases described in the literature, but far more in the popular media. As with most types of burns, the primary mechanism of damage is thermal. However, burns caused by hot liquids or hot objects are more severe at the skin surface with less damage as the distance from the skin or heat source increases. So in other words, the skin is damaged first, followed by the underlying subcutaneous fat, and if severe enough, finally the muscle. A microwave works by causing polarized molecules like water in food to oscillate or vibrate, generating heat. So with a microwave burn, the tissue with the highest water content will be more affected. As muscle tissue has higher water content than fat, it will heat to a greater extent, resulting in a more severe burn to the muscle than the subcutaneous fat. The skin closest to the microwave emitter will also be damaged. This particular pattern of sparing can be helpful in diagnosing microwave burns. It's important to note that microwaves can also be used to heat liquids that cause unintentional or inflicted burns. The next case is a 5-week-old little girl who was brought to an emergency department by her parents after they noticed multiple burns. According to the mother, she had set the child on an ironing board in front of the microwave as she was heating a bottle so she could run upstairs to get a change of clothes. When she returned, she found the child fussy with burns on their skin. In the emergency department, the infant was noted to have full thickness burns to 11% total body surface area. Initially, they suspected electrical burn, but the scene investigation showed no nearby electrical source or charring to the child's sleeper. The pattern of the burn was also not consistent with electrical burn, and biopsies showed sparing of tissue levels with relatively undamaged subcutaneous fat between severely burned skin and muscle, consistent with placement in a microwave oven. The microwave was subsequently tested and did not show any evidence of malfunction. Over the next month, the child underwent 4 surgeries for debridement and grafting, ultimately requiring amputation of half of her left hand and right foot. Stun guns are another device that has been used to abuse children. Stun guns use metal electrodes or probes to deliver high voltage, low amp electric shocks. This requires direct contact and close proximity. In other words, the subject has to be touched with the device. Stun guns cause uncontrollable muscle contraction, pain, numbness, and loss of balance with incapacitation that can last up to 15 minutes. In general, stun guns are used because they've been shown to cause no permanent physical injury. However, they can cause superficial burns. The typical pattern is 2 symmetric circular burns about 0.5 centimeter in diameter, 5 centimeters apart. 4 burns in a row can also be seen in more fleshy parts of the body if the recessed probes also make contact. If recent, the injuries may appear slightly raised and red, and if healed, as post-inflammatory hypopigmented circular macules or spots. However, there also may be no visible injury. Of course, the neurodevelopmental injury of being abused in this manner could cause lifelong adverse health consequences. Stun guns can also result in death. Case 4 is a 7-month-old little boy who was found deceased in his crib. Foster mother reported she had given him too much cough medication because he'd been fussy and feverish, and scene investigation did show 3 partially used bottles of over-the-counter cough and cold medication. Autopsy showed that his weight was that of an average 2.5-month-old, and skin exam was significant for 7 paired small red round lesions on his chest and right hand. Drug testing was positive for over-the-counter cough and cold medication, but well below toxic or fatal dose. On further questioning, foster mother began to act suspiciously and her purse was searched, which was found to contain a stun gun. Foster mother subsequently confessed to using the stun gun to try to make the infant stop crying. Tasers can be used similarly. Although there are no published studies on their use in child abuse, a quick internet search shows several cases. Tasers also deliver a high voltage electric shock, but are shaped more like a firearm and can be used up to 15 to 35 feet away from the subject. When the taser is discharged, 2 barbed prongs with attached wires are fired and embed in the skin through up to 2 inches of clothing. The trigger is then pressed, activating the current. Like stun guns, a shorter discharge of 1 to 2 seconds will cause muscle contractions, numbness, confusion, and loss of balance, whereas a longer discharge of 3 to 5 seconds will leave a subject unable to function for up to 15 minutes with subsequent stiffness and pain. Unlike stun guns, however, these cause puncture wounds in addition to burn injury, and if not removed by a medical professional as recommended, can cause more severe local injury when the barb is forcefully removed from the skin. Because these are fired from a distance, the injuries are typically relatively far apart, and because of their ability to penetrate, carry additional risks of injury to vasculature, genitalia, eyes, and lungs. Take another short break for any questions.
We do have one question. The question is about the microwave burn. Are people putting children in microwaves or on microwaves? She was not sure how the microwave burn occurred in scenario 3.
Yeah, so that actually was a case of the child being put into the microwave. Most microwaves undergo a lot of pre-market testing, and so it's not from the child being set on or nearby the microwave. It's actually from the child being placed in the microwave.
And that's the only question at this point.
All right. So in the next section, I'm going to talk a little bit about unusual bruising and bleeding as a manifestation of child abuse. First is hemotympanum. So in general, accidental injury, including bruising to the ear, is pretty uncommon in childhood. Hemotympanum, or blood behind the eardrum, can be caused by blunt force trauma, penetrating trauma, something entering into the ear canal, or barotrauma, which occurs from a pressure change within the ear canal. That can happen with a blow to the side of the head. Hemotympanum can also be associated with skull fractures or infection. The forces leading to this type of injury can cause perforation of the tympanic membrane or eardrum, long-term hearing loss, deformity of the ear such as cauliflower ear, and or brain injury. Subgaleal hematomas are sometimes seen in newborns after vacuum-assisted deliveries. However, they can also be seen as a result of traction injury in cases of abuse when a child's hair is violently pulled. This leads to bleeding between the scalp and the skull, and on exam, the child will have boggy swelling that's often tender. These can be associated with skull fractures as a result of blunt force trauma to the head as well. The forces required to cause subgaleal hematoma may also result in traumatic alopecia or hair loss. Briefly, traumatic alopecia occurs as a result of abusive hair pulling or when a caregiver uses the hair to grab a child. This usually appears as a patchy spot on top of the head, and the underlying scalp may appear either normal or may have petechial bruising. This does have to be differentiated from a number of other medical conditions such as tinea capitis, a fungal infection in which the skin appears scaly, traction alopecia, which can be seen from tight braids or hairstyles, alopecia areata, an autoimmune disorder in which the body attacks hair follicles, or trichotillomania in older kids, a disorder in which a person pulls out their own hair. The picture in this case is a 4-month-old little girl who presented with multiple abusive injuries, including these 2 areas of hair loss on the top of her head, which parents attributed to sleeping in her crib every night. Infants can lose the hair on the back of their heads from rubbing their scalp against the mattress as they're lying on their backs, but the location in this case was not consistent with that explanation. Sublingual hematoma, or bruising on the floor of the mouth beneath the tongue, is typically caused by blunt force trauma. This can be seen with forced feeding when a utensil, bottle, or other object is violently shoved into a child's mouth. Children can present with a mass under the tongue, a purple discoloration of the floor of the mouth or tongue, deviation of the tongue, or respiratory distress. Imaging such as head and facial bone CT should be strongly considered in these cases, as sublingual hematomas can also be seen in the context of a mandible or jaw fracture, such as from a direct blow to the jaw. The next case is an 8-month-old female who was brought to the emergency department by paternal grandmother. According to grandmother, she or father, history had changed a little after she presented, had put her to sleep on the couch. She then went to go get ready for bed, and approximately half an hour later, heard her suddenly start screaming. Grandmother comes back out to the living room and finds her laying face down on a bundle of toys. When she picks her up, her lip is bleeding, and she notices bruising on her face. 3 hours later, she is brought to the emergency department, and exam shows bruising to the face and chin, as well as sublingual hematoma. Imaging showed intracranial and mandibular or jaw fractures, which are seen here, as well as a grade 2 liver laceration and right adrenal hemorrhage, which we'll talk about a little later. A subungual hematoma is a collection of blood that occurs underneath a fingernail or toenail. This is typically the result of trauma and can be seen when a child accidentally slams their finger in a door, or abusively when a child's digits are pinched, hit with an object, or bitten. This causes blue-black discoloration under the nail and throbbing pain. Infection can also develop and the nail may be deformed or permanently lost. Subungual hematomas typically resolve over time by themselves, but may also require drainage, which involves making a hole in the nail. As an example, the next case is a 7-month-old male who presented to the emergency department with Child Protective Services. On the day of presentation, CPS became aware that father was having unsupervised visits with him. When they went to pick him up, they noticed bruising on his face, so brought him in for medical evaluation. On exam, he had what appeared to be a bite injury on his cheek, bruising to both ears, and 4 subungual hematomas, including to his big toe, which is shown here. He also had multiple healing fractures on imaging. The use of restraints are another way in which a child may be abused. This typically involves a caregiver using something like a rope or cord tied around a child's wrists, ankle, or neck to prevent them from moving around freely. However, handcuffs, shackles, and wire have also been used. Children who have been restrained may present with linear bruising, abrasions, indentations, or scars around their extremities or neck. They may or may not be circumferential, depending where the pressure is on the restraint, and injury to the corners of the mouth can also be seen if a gag is used. Fractures or dislocations have been documented in cases of torture or suspension, and depending on how tightly the restraint is applied and for how long, complications such as gangrene and amputation may result. However, physical exam may also be normal. Restraints around the neck require additional consideration because of the risk of strangulation. Ligature strangulation may be associated with petechial bruising or small bruises to the face or neck as a result of compression or obstruction of the veins, but not the arteries. Blood continues to flow in but cannot flow back out, causing increased venous pressure and rupture of blood vessels leading to petechiae and subconjunctival hemorrhages or bleeding in the white part of the eye. With complete obstruction of blood flow, as can be seen in cases of suspension or hanging, petechiae are not typically seen. Children can also present with vertical abrasions on the neck, which can occur as the child is trying to remove the restraint. Diagnosis of strangulation as a result of restraints or ligatures is typically based on a child's disclosure of not being able to breathe, evidence of end organ hypoxia, or subsequent symptoms like hoarseness, weak voice or cry, cough, difficulty swallowing, or pain. Very frequently, there is no external evidence of injury. One case involved in the torture literature was a little boy who was tied by the neck to a shower head, forcing him to stand or strangulate if he fell. One mimic of restraints are elastic band injuries. These are sometimes confused with injuries from restraints and are caused by decreased blood flow to the tissue from elastic clothing, such as socks or sleeper bottoms. These typically present as red or brown curvilinear lesions, usually concave up and often on the calf. They may or may not be circumferential and do not require any sort of treatment. I do want to briefly talk about subconjunctival hemorrhages since I did mention them as a possible presentation of strangulation or asphyxiation. Subconjunctival hemorrhages or bleeding in the white part of the eye are relatively uncommon in children and are typically caused by blunt force trauma. They can also be seen as a birth injury, but typically resolved by 2 weeks of age, or in the context of pertussis due to severe coughing and invasion of the organism into vessel walls, making them weaker. However, in a non-mobile child without a history, these are concerning for abuse. Subconjunctival hemorrhages are sometimes confused with retinal hemorrhages or bleeding in the back of the eye, which are not visible on external exam. The final presentation I want to mention in this section involves genital bruising. This is a case of a 14-month-old little girl who was brought to the emergency department by her mother for a diaper rash that she noticed after the little girl returned from her father's care. On her exam, you can see she had 2 large red bruises on the right buttock. Sexual abuse is sometimes not considered in this age group, or physical abuse may not be considered if the focus is on sexual abuse. On further investigation, father was found to have child pornography on his computer and father-daughter pornography on his phone. Since it can be difficult to differentiate physical and sexual abuse when injury to the genitalia is involved, workup for both should be considered and was completed in this case. Take another short break for any questions.
I do not have any questions right now.
All right, moving on. The next section I want to talk about is hygiene or harmful hygiene practices. Other than guidance on foreskin care, there's limited information on hygiene readily available from organizations like the American Academy of Pediatrics. And there's really a pretty wide range of advice given by pediatricians. Some recommend no washing inside a baby girl's vulva or vagina, while others recommend gentle separation and cleaning. This variability is also reflected in the literature. So parents are largely left to figure things out on their own based on their own experiences growing up and societal norms. For most parents, that's enough. However, there are also parents that excessively focus on their child's genitalia, subjecting them to painful hygiene practices, frequent inspections, or application of medicines for perceived genital problems. There are other cases that constitute medical child abuse with a focus on the genitalia. For example, a parent reporting a long history of genital problems not verified by a medical provider, resulting in multiple invasive procedures such as pelvic exams with or without anesthesia, surgical scopes, or surgical procedures. There are still others that constitute overt sexual abuse. For example, a father using diaper ointments on his daughter's genitalia, which involved penetration and masturbation. Based on the literature, this primarily involves girls, and the involved parent may have experienced sexual abuse or abnormal genital care practices themselves. Regardless, genital practices causing pain, injury, or psychological distress or leading to unnecessary medical care are abusive. I'm going to go through a couple of case examples that are published in the literature from other child abuse programs. The first is a 9-year-old little girl who was referred to a child advocacy center for a sexual abuse evaluation. There was an ongoing custody battle between parents, and mother had made 9 allegations of abuse against father in the 3 years they'd been apart, all of which were unsubstantiated. As a result, the patient had undergone multiple forensic interviews and medical exams based on the allegations, and mother and grandmother reported regular sexual abuse exams that they performed themselves at home. Despite instructions from CPS to discontinue these exams, they continued, and custody was eventually given to father. In her forensic interview, the little girl described how these exams were performed, and that sometimes she would say, "It hurts," but they would continue. The child protection team advised the mother that to not discontinue the exams would be abusive to the child. This was also ordered by the court, and the child was referred to mental health services. The next case involves a 5-year-old little girl, also referred to a child advocacy center for sexual abuse evaluation. Similar to the last case, there were ongoing custody issues between the parents, and mother had made multiple allegations of sexual abuse against various individuals, including the girl's father, all of which were unsubstantiated. This resulted in multiple forensic interviews and medical evaluations, same as before. The mother also reported daily interviews and genital and anal exams after the child returned from school or her father's home, which involved having her lie naked from the waist down on the kitchen floor so mother could examine her with a flashlight. Mother had also been applying a yeast cream to the vaginal area for the last 1.5 years, despite medical advice to stop. During the evaluation at the Child Advocacy Center, mother reported that she had continued these practices despite instructions by CPS to stop. The child did not make any disclosures during her forensic interview and did not mention the exams when asked about touching of private body parts. As before, the child protection team instructed the mother to discontinue the exams, and the child was referred to mental health services. We also rarely see injury to the nose related to inappropriate care. One case report describes a mother who actually used a bobby pin to scour her son's nose, sometimes causing bleeding. This type of practice can lead to destruction of the nasal septum and or columella, the tissue that is between the nostrils. This picture is of a 2-year-old little girl in foster care who is being seen regularly by her primary care physician and a gastroenterologist for feeding difficulty and poor weight gain. A nasogastric tube, or NG tube, had been placed, and a G tube was being considered. In the days prior to presentation, Child Protective Services received 2 separate reports from individuals who had seen the foster mother hitting this child. As a result, she was brought to the emergency department for medical clearance. There she was found to have multiple skin injuries, including a patterned burn, dental injury, nasal septum breakdown, which you can see here, and 9 fractures on imaging, including a fracture to her jaw. The trauma to her nose was from repetitive injury to the nasal septum, the tissue between the nostrils, and foster mother described having to restrain her to forcefully insert the NG tube. Dental injuries are not uncommon in cases of abuse, again because the mouth is often a target as the talking, crying, feeding part of the child. As a result, practitioners should be vigilant when patients present with unusual, unexplained, or poorly explained injuries to the mouth. This picture comes from a case report of 3 siblings who were followed by a local dentist. This 13-year-old boy was missing all 8 permanent incisors, all 8 of his front teeth, but was otherwise healthy. His younger brother had 3 lower incisors that were missing, and his younger sister had 2. All of the children reported that the teeth had just fallen out. It was not until the little girl presented to another dentist with a bleeding socket that she eventually disclosed that when they misbehaved, one parent restrained the child while the other pulled out the tooth. The children were placed in foster care and no further teeth were lost. There is significant risk of infection, cosmetic and functional disfigurement, speech and feeding difficulties, and social consequences with this type of injury, not to mention disruption of sleep in school due to pain and the lasting neurodevelopmental effects of such abuse. In this case, the child's remaining teeth had all migrated centrally, and all 3 were eventually fitted with partial dentures. Take another short break for any questions.
I do not have any questions right now.
I've been mentioning torture here and there throughout the presentation, so I want to pause briefly to talk about this manifestation of abuse. There has been some debate about what the difference between child abuse and torture really is, but there are cases in which no other word really seems to sufficiently describe what a child has suffered. In practice, the word has typically been used in cases of I know it when I see it. In 2014, a group of child abuse pediatricians tried to better define torture as a longitudinal experience characterized by at least 2 physical assaults or 1 extended assault, 2 or more forms of psychological maltreatment and neglect resulting in prolonged suffering, permanent disfigurement or dysfunction, or death. Unlike other forms of maltreatment, women were involved in all cases they studied, and most primary abusers were not first-degree relatives. The majority of perpetrators just demonstrated little or no remorse, and almost all at least partially confessed to their abuse, but blamed the victim for causing the abuse to be necessary. These cases also often involved everyone in the home. For example, siblings were coerced into participating in or encouraging the abuse, likely out of fear and their inability to escape the situation. As torture has been discussed in detail in other lectures in this series, I will not go into more details or case examples here. Infanticide or infant homicide is unfortunately not uncommon, and it has happened for centuries by a variety of mechanisms. One of these is inserting needles or other sharp objects into an infant's brain through their fontanelle or soft spot. There are dozens of cases in literature of children and even adults who are found to have intracranial sewing needles, often incidentally, that were felt to represent attempted infanticide. Sewing needles and other sharp objects have since been used in a variety of contexts on different parts of the body, including the abdomen and the chest. If not fatal, the penetrating injuries can cause a number of complications, including hemorrhage and infection. Diagnosis requires a high index of suspicion, especially if the insertion site has since healed. X-rays can be useful, but really only if the object is radiopaque. Treatment typically involves surgical removal, which can be difficult depending on the location of the insertion, for example, the brain, and management of any complications. Abusive cases of tattooing or intentional scarring have also been described. As an example of this, the mother of a 13-month-old boy called his primary care physician because of a 6-week history of severe pain whenever he tried to walk and increased irritability and fussing with diaper changes. The little boy had recently been seen for easy bruising, so the physician referred him to the laboratory to check his blood counts. There he was noted to have facial bruising, and Child Protective Services was contacted. He subsequently presented to the emergency department, where he was noted to have bruising on his forehead and ear, as well as parallel linear bruising to his thigh and chest. He also had a torn upper labial frenulum and crusted lesions on his heels and perineum, which is the tissue between the genitalia and the anus. skeletal survey was ordered and showed 3 sewing needles, 1 in his perineum and 2 in his buttocks, as well as fragments of small nails or tacks in the heels or soles of both of his feet. The mother subsequently reported that her significant other was fascinated with needles, and on further investigation, he did admit to inserting the needles into the child. The child was taken to surgery, and all but the needles in the buttocks were removed. These 2 later developed into infections, and the needles were expelled when the lesions were opened. Forced exercise, exertion, or position holding is another unusual type of abuse that involves a child being made to exercise or hold an often uncomfortable position for extended periods of time, sometimes to the point of exhaustion. An example of this is a child being made to stand with their arms out holding books for hours. If unable to maintain the position or complete the exercises, the child may receive additional punishment. In addition to pain, forced exercise can result in a number of serious consequences, including heat stroke, dehydration, and elevated creatine kinase, which can indicate injury to muscle tissue. With extensive muscle injury, a child may develop something called rhabdomyolysis. This can present with muscle pain, weakness, vomiting, confusion, tea-colored urine, and kidney failure. Children who suffer this type of abuse may also have abnormal growth curves, either losing weight or failing to gain weight as expected. Another possible consequence is presented here. This is a case of a 9-year-old little girl who was brought to the emergency department by EMS after becoming unresponsive at home. At the time, she was living with her father and paternal grandmother due to child abuse by mother. On the day of her death, she had stolen a piece of candy at school and denied it. As a result, her grandmother forced her to run sprints in the yard carrying sticks. After 3 hours, she collapsed and began to vomit and seize. In the emergency department, her serum sodium was found to be 117. She was admitted to the pediatric intensive care unit and died 3 days later. Autopsy showed massive brain swelling with herniation and pulmonary edema. The cause of death was determined to be something called hyponatremic encephalopathy, which is a life-threatening emergency that is sometimes seen in marathon runners and presents as altered mental status due to low serum sodium. In this case, it was unclear whether the child's low serum sodium was due to dehydration or water intoxication, as the child was actually allowed water breaks, so may have been drinking frequently to try to rest and avoid further exertion. Any questions at this point?
I have 2 questions posted right now. First was just a clarification regarding torture. Did you say that torture is most likely to be caused by first-degree relatives, meaning the child's mother or father?
It's actually most likely not to be caused by a first-degree relative. They were often seen in like family-arranged aunts, uncles, foster care, that kind of thing.
Okay, thank you. And then the second question is, when does force feeding, demanding a child to sit at the table until a meal is consumed, or saving and serving uneaten food until consumed for days possibly, when does that rise to the level of child abuse?
I think that's going to be kind of dependent on the case. I mean, as a general rule, pediatricians do often recommend that, if a child doesn't want to eat at the time, that the food be saved and, offered to them later if they become hungry. However, if the food that is the only food that they're offered and it's withheld to the point where the child starts suffering other consequences like dehydration, things like that, I think it would rise to the level of abuse. Again, though, it'll kind of depend on a case-to-case basis.
A third question has popped up now. What is the normal range for NA to be for a healthy 9-year-old child? I'm not sure if that's sodium.
So it's actually, that's the sodium, and that was the same as the adult level that I talked about earlier. 135 to 145 is considered normal, so 117 would be extremely low.
And that's all I've got for now.
All right. In this last section, we're going to talk about some other unusual injuries and learn a little bit about anatomy in the process. So retropharyngeal injury or injury to the back of the throat can be caused accidentally when a child has something like a toothbrush in their mouth and they fall, causing it to penetrate the posterior throat. It can also be caused abusively with forceful insertion of an object such as a finger or spoon into the back of the mouth. This can cause a laceration or tear to the tissue or the mucosa, which can present as bleeding from the mouth, drooling, difficulty breathing or swallowing, swelling, which can be life-threatening given its proximity to the airway, infection, or subcutaneous emphysema, which is air beneath the tissue or the skin. The lack of a clear history of an accidental injury event in these cases should raise concern for inflicted injury, and the diagnosis usually requires endoscopic visualization, although may be suggested on X-ray, CT, or MRI. This is a picture of a retropharyngeal tear that did actually cause subcutaneous emphysema or air in the tissues. This child also had multiple other abusive injuries. Post-traumatic pulmonary pseudocysts are another manifestation. Basically, these are spaces in the lungs that are filled with air, fluid, or blood. They're usually caused by blunt force trauma to the chest when the lung tissue is lacerated or torn. There's negative pressure on the lung tissue, so then air or other substances will then fill those spaces, which can become trapped. Accidentally, these can be seen in cases of motor vehicle accidents, although there's also a case in the literature in which an adult was attacked by a cow. These may be asymptomatic or present with things like chest pain, shortness of breath, or coughing up blood. They can be difficult to diagnose because they can be confused with other conditions such as abscess or infection, tuberculosis, or cancer. They're typically missed on X-ray and do require CT. Most self-resolve, although surgery may be required if the pseudocyst ruptures, bleeds, or becomes infected. One case in the literature describes a 2-year-old little boy who presented to the hospital with abdominal pain and decreased appetite and sleepiness. In the ED, he was noted to have fever, elevated liver and pancreatic labs, probably due to unrecognized abdominal trauma. The admitting providers, however, were concerned about pancreatitis and sepsis, so admitted him to the hospital on antibiotics. Trauma was briefly considered, but skeletal survey was normal, so was not pursued further, and the hospital-based child protection team was not consulted. CT was also obtained and showed 3 cavitary lesions at the base of the right lung, one of which had an air fluid level. 10 days later, he was discharged on oral antibiotics. 9 days after that, he returned to the emergency department unresponsive, at which time he was declared dead with multiple abusive injuries. Autopsy showed pattern injuries over his buttocks, rib fractures, an upper labial frenulum tear, liver lacerations, pancreatic scarring, lung contusions, and on lung biopsy, a large pulmonary pseudocyst. Mother's boyfriend subsequently confessed to beating the child's midsection to the point where he had blood and bile-stained clothes. The authors state that in retrospect, there were a number of indicators that, if recognized, could have prevented this child's death. Chylothorax in children can be caused by a number of conditions, a number of systemic illnesses. The thoracic duct is part of the lymphatic system, and it carries a fluid called chyle, which contains things like white blood cells and emulsified fat. If that ruptures, the fluid can flow into the pleural cavity, which is the space between the lungs and the surrounding membranes, leading to chylothorax. You can see in the picture here how close the thoracic duct is to the spine and posterior ribs. There are multiple case reports in the literature of child abuse causing chylothorax. These may be associated with rib fractures or hyperextension of the spine or vertebral fracture, again, related to their proximity to those structures. Typically, it's thought to be due to shearing, due to acceleration, deceleration, or compressive forces against those structures, although spinal hyperextension in cases of shaking can also cause that. Often children will present with respiratory distress, can actually present with immunodeficiency or altered immune system because of the loss of white blood cells and malnutrition from loss of fat and protein. Typically, children with this type of injury do not present until 2 to 10 days after the trauma. This will not usually cause pain because the fluid is not actually irritating to the pleura or the membrane around the lungs. Treatment usually involves a special diet or IV nutrition, which causes decreased flow to the thoracic duct so that it can repair itself, but can also require surgical repair. The advice from this article is that anytime that there's a chylothorax that can't be explained, to keep abuse on the differential. There are also cases of reported fluid in the abdominal cavity related to injured thoracic duct. As an example, this is a 6-month-old little girl who presented to the emergency room with her mother due to a one-day history of congestion and difficulty breathing. On exam, she was noted to be in respiratory distress, and chest x-ray showed a left-sided infiltrate or fluid in her left lung. She was started on antibiotics and steroids and admitted to the hospital. On admission, the team noticed that she had a rash or a bruise on her forehead and swelling of her left arm and leg. X-rays were obtained and showed fractures, which mother reported were from falling off a bed a week prior. The hospital-based child protection team was consulted and noted additional injuries, including bruises over her eyelids, right thigh and chest, and left cheek, as well as 3 healing burns on the left arm. Skeletal surveys showed 15 other fractures in various stages of healing, including multiple rib fractures bilaterally. Brain MRI showed a left subdural hematoma or bleeding around the brain. The child's respiratory distress worsened and she was transferred to the PICU, where the left-sided fluid collection was drained, and fluid analysis was consistent with chylothorax. The mother later confessed to squeezing her rib cage and throwing her against a bed and twisting her left arm and leg until she heard a pop. The adrenal glands are located just above the kidneys and produce hormones such as adrenaline and cortisol. Children have relatively larger adrenal glands when compared with adults and may sustain injuries such as contusion or bruising, hemorrhage, laceration, or complete transection in accidental cases of motor vehicle accidents, falls from a great height, or crush injury, and abusively with blunt force trauma to the torso. Injury is thought to result from compression of the adrenal glands between surrounding structures and the vertebral column. When injury is just to one adrenal gland, it is typically clinically silent, although this injury can be fatal if it involves both adrenal glands, as that can lead to adrenal insufficiency. Generally, these serve as a marker of severe external force and are often seen in the setting of massive abdominal trauma. In summary, child abuse manifests in many forms, and unless we maintain a high index of suspicion, it may be missed. Unusual injuries and unlikely histories should raise concern for abuse, and a child's disclosure, regardless of how bizarre it may sound, may be the only indication of abuse. These cases can be difficult to identify, but there are medical providers throughout the state with advanced training and experience in child abuse pediatrics that may be able to help. These are my references, and I would be happy to take any additional questions.
Thanks, Dr. Petska. I have 2 more questions that are posted. First is, what is the difference between a retropharyngeal injury and forced feeding?
So basically, forced feeding is any time that a child has something forcefully inserted into their mouth, so spoon or bottle, whatever. The injury that results from that forced feeding is what we're talking about when we talk about retropharyngeal injury. So you may see, for example, the sublingual hematoma we talked about, depending on whether the tissue under the tongue was damaged. You can also see a frenulum tear if the lip is separated from the gum, or the tongue from the floor of the mouth, or retropharyngeal injury if the object is pushed far enough back in the throat.
Okay, my final question today then is that the comment is, most injuries are in combination with other forms of abuse or other injuries. Are there some of these that are usually done solo?
Yes, actually, almost all of these had case reports in the literature where that was the only presentation of abuse. As I mentioned, there certainly is helpful when there are other injuries, because that can kind of suggest that diagnosis, but all of these can occur independently, and really without that high index of suspicion can be missed.
So that's all we have for questions. I want to thank everyone for being with us today, and thank you, Dr. Petska, for your presentation. You can log in now at ocpe.mcw.edu to complete your evaluation. Please join us next month when Dr. Casey Brown will give a presentation on common patterns of injury and what they mean. Thanks and have a great day.